So greetings to everybody. Welcome to this presentation. The title is Alcohol and Heroin Abuse, Repetitive Mild Traumatic Injury. What can we see under the microscope? My name is Gabor Kovacs and I work at the University of Toronto and University Health Network. So the overview of the presentation is seen in this slide. So first, I would like to define what we call neurodegenerative diseases. Then I would like to show a few slides about chronic traumatic encephalopathy, what is seen under the microscope, also what is seen under the microscope in alcohol abuse and also in drug abuse. So first, when we see patients with various clinical symptoms in neurodegenerative diseases, we think that the clinical symptoms are related to the damage and involvement of functional systems of the brain, which means that there are connected groups of nerve cells which go wrong, and this causes clinical symptoms. And associated to neurodegenerative diseases, there's two major classes of clinical symptoms. One is cognitive impairment, and one is movement disorders. However, many other conditions can lead and produce the same symptoms. So not only neurodegenerative diseases, also inflammatory disorders, vascular lesions, cerebrovascular disease, or conditions related to metabolism, either hereditary or acquired, or toxic agents, eventually tumors, or trauma can lead to cognitive decline. So when somebody develops cognitive decline or movement disorders, these are the conditions what the physician has to exclude and think about before setting up the final diagnosis. Now let's dive into the details of how we really define neurodegenerative diseases. And I do this first because I would like to position chronic traumatic encephalopathy in the field of neurodegenerative diseases or other conditions. So let me go back more than 100 years in time, and this is the beginning of the 20th century. And researchers at that time, using very cheap staining methods, saw unusual, strange structures in the brains of individuals who died due to cognitive impairment or movement disorders. These structures have not been seen in individuals who died for other diseases or other clinical symptoms. I would like to show you these strange structures. These are these pinkish kind of bodies in the cells, and they can be in different parts of the cells, as you see here, and they can show also fibrillar appearance. And also they can be outside a cell, which they called plaques at that time. Soon, and I'm still 100 years in time back, researchers developed so-called silver staining methods. And with these, they found that these abnormal structures can be seen with silver staining, and these are the black colored alterations in this image. And soon they recognized that not only nerve cells can show these kind of inclusions or bodies in their cells, but also the supporting tissue, the so-called glial cells, can show this. In the 1990s, they discovered that the protein processing system is very important in neurodegenerative disease, and this is the ubiquitin proteasome system. So soon, the definition of neurodegenerative diseases finally concluded that it is characterized by regionally distinct nerve cell loss and deposition of proteins. This is the major novelty of the definition, and it was recognized that the proteins can be inside or outside a cell, and if they are inside a cell, they can be in different parts of the cell, and not only in nerve cells, but also in so-called supporting tissue, which is the glial cells. Now, with the molecular biology and new discoveries in genetics, and using very novel methods, going into very, very small levels of visualization with, for example, the cryo-electron microscopy, and just think that we are talking about 1/1,000,000th of 1 millimeter size, or even 10 millionth of an inch size. So they are able to visualize and to examine these molecules at these very small size levels. And they found that the molecules in disease, in neurodegenerative disease, show different shape, and they call it distinct fold of filaments. And these different shapes are related to distinct cell-to-cell propagation patterns in the human brain, leading to functional system-specific sequential involvement of brain regions. Now, these filaments, if they build up, they create larger, not normal, so abnormal structures, which we can, neuropathologists, under a light microscope, which is a simple microscope, detect and see. We also use in the diagnostic practice so-called antibodies, using the method called immunohistochemistry to visualize these bad altered proteins, and we usually see them in brown or reddish color. So as a summary, if we see a patient with neurodegenerative disease, we have to classify first on a clinical level, then thinking which brain regions are involved, then the predominant protein, and think where this protein, which is not normal, localizes in the central nervous system. Now, if I want to talk about chronic traumatic encephalopathy, I have to talk about a protein called tau. I would like to mention that altogether, currently we think that there are at least 6 major proteins associated with the adult onset neurodegenerative diseases, but I will have to talk about tau if I would like to talk about chronic traumatic encephalopathy. So tau protein, we all of us have in our brain. It's a very important protein, keeping up the kind of the skeleton of the nerve cells, but it also has some role in the physiology of supporting cells, the glial cells. In disease, the tau isoforms go wrong, and either the 3-repeat or the 4-repeat tau isoforms accumulate in the brain. And this is what we see in the microscopy, which means that we see, using immunohistochemistry, different outlooks, so we say morphology, of the nerve cell, astrocyte, supporting cell, or oligodendrocyte inclusions. Now, let me talk about chronic traumatic encephalopathy. Now, I did this introduction because indeed, in chronic traumatic encephalopathy, there is a neuropathological alteration, namely the accumulation of tau protein in an abnormal way, which justifies that we position chronic traumatic encephalopathy in the group of neurodegenerative conditions. The classical definition of CTE, this is the abbreviation I will use in my lecture, is that CTE is a neurodegenerative disease associated with exposure to repetitive head impacts, including those in contact and collision sports. Now, the clinical definition and the clinical features of CTE is very difficult to define, but these include non-specific cognitive, neuropsychiatric, and motor movement disorder impairments, and progressing finally to dementia. Now, currently, research diagnostic criteria termed clinical symptoms as traumatic encephalopathy syndrome. This is how CTE pathology looks like under the microscope, and everything what is brown is not normal. You don't see this in a normal brain. This is the so-called depth of the cortical sulci. So this is some place where the brain makes deep intrusions, and at these places you see accumulation of pathological tau in the supporting glia, which is astrocytes, and in the gray matter under this you see also perivascular patchy accumulation of nerve cell and astrocytic, so supporting tissue tau protein, which is not normal. So the classical neuropathological definition is that we see patchy accumulation concentrated around vessels in the depth of the sulci. as shown here. This is, for example, a vessel, and you see accumulation of tau in nerve cells and also in supporting cells. Now, Anne McKee and colleagues defined 4 stages of how tau protein accumulates in the brain, and they say that this is there is a sequential involvement, starting with small foci of this pathology, expanding into further regions, and finally involving the whole brain. Now, the recent 2021 diagnostic criteria defines CTE lesion as a pathognomic lesion. The tau aggregates in nerve cells with or without astrocytes, so supporting cells, and they list different further pathological alterations as diagnostic of CTE. And if you see more than 5, then you can call it as a high CTE level, and if less than 5, then low CTE level. However, in CTE, not only tau is accumulating, but other types of proteins can be seen, like seen in other neurodegenerative diseases. So, for example, amyloid beta, like in Alzheimer's disease, or TDP-43, or alpha-synucleinase in Parkinson's disease. However, tau is always the most important and pathognomic lesion to diagnose CTE. Now, a further evidence that CTE is an independent entity came from these very specialized cryo-electron microscopy examinations. These were able to show that the molecular level structure, how these filaments and molecules look like in CTE, is different than in any other neurodegenerative disease. This was a very strong support towards the concept that CTE represents a neurodegenerative condition which is distinct from any other known in the literature. Also, there were experimental studies which supported the concept that the tau protein is abnormal and can be propagated from cell to cell, as it has been shown for other neurodegenerative proteins. Here I show you this historical paper, the cryo-electron microscopy paper, which was able to show that the outlook of the molecule in CTE of bad tau is distinct then from other proteins in other neurodegenerative diseases with tau protein. So as a conclusion about CTE, we can summarize the literature observations as follows. Repetitive mild traumatic brain injury leads to changes in the human brain detectable by microscope. The microscopical changes look like a neurodegenerative disease and is associated with abnormal structures composed of tau protein. Tau pathology and the high resolution structure of tau protein is unique and distinct from other neurodegenerative disorders, showing accumulation of abnormal tau. Importantly, other abnormal proteins can also accumulate variably in the brain in CT, but tau is always the most important and hallmark lesion. Ongoing studies have to still define how the clinical symptoms relate to the changes what we see under the microscope in postmortem neuropathology studies. So the term CTE is the best used when it is used by a neuropathology postmortem examination, and the clinical symptoms should be summarized under a different terminology. And this terminology came in a recent publication from the National Institute of Neurological Disorders and Stroke Consensus Diagnostic Criteria, which recommends a stepwise process for diagnosing the clinical symptom associated with CT, which is termed as traumatic encephalopathy syndrome. Based on these steps, there are levels of how this is defined, and that is, for example, suggestive of CT in a living patient, possible CT, probable, but the definite CTE can be diagnosed only with post-mortem examination. Now let me switch to the next topic before the final conclusion. The next topic will be about alcohol abuse, and then I will talk about drug abuse. So brain damage caused by alcohol abuse is usually associated with either nutritional deficiency, because the patients or individuals who consume a lot of alcohol usually don't eat well or lose so their nutrition can have severe deficiencies, mostly vitamin B. And also there might be changes which are related to liver disease, which is of course an effect caused by the alcohol abuse, related alterations. There is a further damage which is directly caused by alcohol, and this is called alcohol-related brain damage, ARBD. In these cases, we see nerve cell loss in the front part. In medical term, we say frontal part of the brain, where the behavior and personality is organized. Also a hypothalamus, where a brain region which coordinates hormonal function, sleep, or the cerebellum, the brain region that participates in the coordination, movement, and gait. However, there is no pathological tau protein accumulation in alcohol brain damage. So clinically, there might be overlap in certain cases with CTE, but the pathology is completely different. Here are some images, what we see in alcoholic brain damage. This is, for example, the Wernicke encephalopathy, where you see bleeding in a certain place of the hypothalamus, or thinning of the corpus callosum, a structure which connects the two sides of our brain and obviously is very important for interpretation of information. Or the cells look strange in certain areas of the brain, or in the cerebellum, there is a very important cell layer which shows damage. Or this is the brainstem, where the middle part can be severely damaged in alcohol abuse. So now I will summarize observations in drug abuse. The limitations when we are studying drug abuse effects is that it is always a challenge to distinguish between substance-specific effects related to the proteins of properties of the drug itself, the influence of adulterants, and secondary effects related to the lifestyle of drug abusers, for example, malnutrition, infection, and systemic diseases. So to really conclude what is really directly related to drug abuse, you have to keep a lot of things in mind, and these are really very difficult studies to organize. And especially that there is some polysubstance abuse, which also complicates the interpretation of results. Now, this is a summary how really what goes wrong in drug abuse. So there are several levels. Either there is a direct toxic factor and the vessels go wrong, there are some lack of oxygen and stroke-like features, then the nerve cells can be lost or the nerve cell processes can be damaged. This is a tabularized summary of the results in different drugs, and very, very briefly, so an increased cerebral pressure and water, which we call edema, can be seen in all as an effect of drug abuse. Cerebrovascular disease, or let's say stroke, can be seen associated to drug abuse. Either lack of oxygen, which we say ischemic, or too much, so bleeding, which we say hemorrhagic. So as you see, hemorrhagic is mostly in cocaine. In heroin, it is mostly ischemic, so lack of oxygen. Then there's infections associated with drug abuse, usually with unsterile injections or nasal substances, and also some related to other components of the drugs. There's a further change, which we described in 2007, which shows that a certain part of the brain called the striatum loses the dopamine innervation. Now, dopamine is very important to coordinate our movement, and it is very important to coordinate our emotions and behavior. Now, importantly, this dopamine can be lost in the striatum of the movement part in Parkinson's disease, and it is lost in the so-called limbic part in the heroin abuse, which is related to emotions and behavior. And the next question is whether heroin abuse accelerates brain aging or not. Now, several studies indicated or suggested that there is a minor but obvious increase in Alzheimer-related changes in the brains of opiate abusers. Now, importantly, these studies were performed in individuals who did not have concomitant HIV infection, because as I told you, it is very difficult then to decide what really causes these changes. So these studies indicated that the amyloid plaque and a little bit of tau pathology was increased in heroin abuse. We also published a study in 2015 where we studied very young individuals, like you see on the left, the HER means heroin. And these individuals are mostly below 30, and two of them are above 30. And we had the opportunity to study control individuals, mostly suicide individuals, who were like the same age range. And we evaluated for the presence of tau pathology. And this is what we found. With the red curve, you see the anatomical brain regions where we found neuritic. Neuritic means that tau in the processes of nerve cells, or neuronal cytoplasmic, which means that in the nerve cell, immunoreactivity. The blue shows the curve where we saw these in the young control individuals without documented heroin abuse. So from this study, what we could conclude is that a few regions show a difference between drug abuse young individuals and controls. And these regions are either related to regions which are prone to develop Alzheimer's disease like neuropathology, or indicates brain regions important for reward-related behavior. So this means that the tau accumulation is supporting a kind of an accelerated brain aging, Alzheimer's disease-like brain aging in drug abuse, but also tau is prone to accumulate in brain regions which are important to the reward-related behavior, which is obviously a very important component of drug abuse. Very importantly, we did not observe supporting tissue tau pathology, so no tau in the astrocytes as in CTE. There was no tau accumulation in the depth of the cortical sulci in a patchy perivascular, around the vessel pattern as we see in CTE. Rather, we observed small amount of nerve cell processed tau and nerve cell tau, but not in these microscopical areas where we see in CTE. And also there was no astrocytic tau. So as a conclusion, we concluded that substance dependence is characterized by pathological changes in circuitries that include reward-related behaviors, and by abnormalities associated mostly with vascular changes, and induction of biochemical cascades that have been identified in neurodegenerative disorders, including accelerated brain aging. So the take-home message of my presentation is the following. The changes seen under the microscope related to repetitive brain injury is called CTE, and it seems to be a very unique and distinct constellation related to repetitive brain injury. These changes are distinct and can be clearly distinguished from microscopical changes seen in alcohol abuse and the drug abuse. Alcohol abuse involves different brain regions than CTE, and there is no distinct accumulation of abnormal tau protein in the brain. Although heroin abuse can show accumulation of abnormal tau protein in nerve cells, however, CTE shows a unique accumulation of tau protein in the brain that involves nerve cells and supporting cells in brain locations, brain regions that are not involved in heroin abuse. As a final conclusion, we still need to understand how the clinical symptoms develop in CTE and how we can translate the neuropathological findings into the clinical practice. Thank you very much for your attention.